Welcome, everyone. Thank you so much for joining us this morning. We're delighted to have people with us from all across the country and in lots of different roles around faith and health and well-being. My name is Esther and I work for the Good Faith Partnership. We work to bridge the gap between sectors to find innovative solutions to some of society's most difficult problems. For the last 18 months, we've been working with the ChurchWorks Commission and Theos to carry out research into the role of faith groups in social prescribing. We wanted to understand how faith groups are engaging with social prescribing and where there is potential for further collaboration, particularly when it comes to Wes Streeting's vision of a neighbourhood health service. And today we're delighted to be able to share with you the key findings and recommendations of our report and our research. And we hope that you find them informative and encouraging for your work. As we begin our time together, I'd like to invite Jude Levemore, who's the Vice Chair for the ChurchWorks Commission, to open on behalf of the Commissioners. Thank you so much, Jude.
Thank you, Esther, and good morning, everyone. It's just delightful to see everybody saying hello to each other in the chat and for me to recognise some names that I know. My name is Jude Levemore. I'm Head of Mission at the Methodist Church, but I'm also Vice Chair of the ChurchWorks Commission, and I've been involved in the Commission since it started in 2021. Delighted to welcome you all here on behalf of myself and my fellow Commissioners. We represent 16 denominations and umbrella organisations. Since the very start of the Commission, we've been aware of the considerable role that the Church can play in supporting good mental health and well-being in our communities and congregations. I mean, we saw that in the pandemic, didn't we, with thousands of churches becoming vaccination centres. And we've seen it since with huge numbers of churches being part of that warm welcome campaign, opening their doors to their neighbours and communities, building deeper connections, helping people flourish in strong communities. For me, I think the most significant thing about ChurchWorks is the second bit of the thing, the works bit. And what we've been doing as a commission is constantly thinking about how we can support the church to work in ways that create new partnerships, support more people in communities, to bring about transformation for the sake of the gospel, to be the good news. We know there are pressures on church leaders, volunteers, church spaces, on you all, but we also know that we want to celebrate those tens of thousands of people who every week are running debt advice courses, gardening groups, befriending, bereavement support, social supermarkets, gardening clubs, you name it, we do it. The church brings an awful lot to the table and we want to celebrate that. So the work that we're launching today and the plans for what come next really reflect how important churches can be in the health and well-being of the communities they serve. I'm delighted to see that the work of Westbury-on-Trym, the Methodist Church in Bristol, highlighted it in the report. You can look at it. They've been running a Space to Grieve cafe for about 4 years now, giving people the opportunity to process grief in a community setting. Connecting this sort of support with social prescribing link workers opened up the space to a much wider group of people, and the link workers are now referring people into Space to Grieve. So the research and the wonderfully practical, I love something that's practical, guide, the how-to guides, I really commend them to you, are being launched today. They offer some really compelling answers to the questions of how can the church and the NHS work together more strategically for the good of our communities. I warmly commend the recommendations that the research has led us to, and we're going to be working to see how we can implement those at all levels of the church's life and in the health system. I'm particularly grateful to Marianne Rozario from Theos, who's been the lead researcher in the project, and to Esther, who you saw earlier from ChurchWorks, who's been so deeply involved in the creation of the report. Thank you to the project steering group, who gave their time and their expertise to support the work, and to the Bishop of London, who wrote such a lovely foreword to the report. And I'm really delighted that we've got the Minister for Social Security and Disability and a good friend of ChurchWorks, Sir Stephen Timms MP, with us, and Charlotte Osborn-Forde, the CEO of the National Academy for Social Prescribing. They're going to be speaking to us later this morning. We really value our partnership with both the government and the NASP immensely, and I want to thank you on behalf of the ChurchWorks Commission for all your support. So, on we go.
Brilliant. Thank you so much, Jude. As Jude mentioned, we're privileged to be joined today by Sir Stephen Timms, and I'd like to invite Minister Timms to join us now and share his reflections.
Thank you very much. I'm delighted to be here. Thank you for inviting me. I apologise that it's a rather brief appearance on my part, but Ben Gregg from my team is on the call and will be all the way through. But I thought I should start by confessing to a bit of a vested interest in this report. Last year, I spoke at the Religion Media Centre on faith's place in our national renewal, arguing that faith communities are key because of the services they provide to their communities that Jude's just been listing, but also because they are centres of belonging at a time when too many people feel they don't belong. And the belonging created by faith groups isn't opposed to, but supports national belonging. But Theos and ChurchWorks very kindly showed me preliminary findings from the research ahead of that speech, so helping me to present my arguments, and I was grateful for that. But that preliminary research showed over 6,000 UK churches, that's about 17% of the total, running wellbeing initiatives with a ChurchWorks Commission partner. Over 2 million people had attended those in January to September last year. As you've been reminded, I'm a minister in the Department for Work and Pensions. I met this week with the National Association for Social Prescribing as part of my work. But I'm particularly interested in the qualitative findings in this final report that social prescribing link workers see church initiatives as valuable because churches prove to be, quote, anchors of the community, provide convening power, offer enthusiastic volunteers and a building, and that they also offer spiritual and pastoral guidance whose importance in modern life has sometimes been overlooked. And this echoes research during the pandemic by the All-Party Parliamentary Group for Faith and Society at a time when I was its chair. We found that 2/3 of councils worked more with faith groups during the pandemic than they had before, and more than 90% of them said their experience of doing so was either very or mostly positive. And when in the research we asked about the benefits of working with faith groups, councils like the link workers said presence in the community, their reach out into the community, their ability to reach disadvantaged groups, their volunteers, and also their professionalism were key pluses. And I think the symmetry between these reports is important because it reflects a growing recognition of the importance of faith groups, especially churches, to their communities and to our national community. The Prime Minister, for example, before he was the Prime Minister, during the election campaign last summer, wrote a letter to faith leaders to commit to, quote, strong partnerships with faith communities. We're starting to see that manifest in the expansion of the Labour Party's team of parliamentary faith champions and in the work of Lord Khan as Minister for Faith at the local level. Local government, I think, is now, after quite a long period of great hesitancy, is becoming much more comfortable working with faith communities. The Mayor of Greater Manchester's faith panel met for the first time in 2021, and that includes representatives from every major faith community, interfaith groups, contributors. It contributes into the Mayor's action networks on things like the environment, child hunger, and others. And I think we're going to see more cooperation between local authorities and faith groups in the future. The Prime Minister, in that letter last summer, promised to promote local faith covenants. And these are agreements between local councils and faith groups, drawing on ideas developed by that all-party group that I mentioned, the APPG for Faith and Society, that aim to tackle similar barriers to cooperation that this report identifies in the health sector. About 25 local authorities have signed a faith covenant. I think a lot more will do. And I do think it's very significant that the final report of the Grenfell inquiry, to which the government is due to respond by the end of next month, it's recommended that there should be a statutory requirement for local councils to enter into partnerships with the voluntary, community and faith sector in their areas. And I think it's very important that churches are able to step up to these new kinds of witness in their communities. So the report here is contributing to a wider debate. I hope for deepening partnership between government, national and local, and faith communities. And I'm hoping today for some new ideas that Ben will be able to tell me about after the session about how we can achieve that in social prescribing. Thank you very much.
Brilliant. Thank you so much, Stephen, for being with us. And we really appreciate your time, and we are encouraged by the potential for faith groups to build relationships with the government at a national and a local level. I'd now like to invite Charlotte Osborn-Forde, who's the CEO of the National Academy for Social Prescribing, up to speak. And Charlotte's going to share about the work that NASP have been doing over the last few years, and the vision for the future and how faith groups fit into that. So Charlotte, over to you.
Thank you, Esther. Can everybody hear me okay? If you could nod, please, Esther. I'm coming through. Am I excellent?
Yeah, all good.
And you're sharing my slides, is that right? Thank you so much. Such a joy to be here, and really encouraging to hear Stephen's words. And yes, my colleague Jim met with Stephen just this week to talk about social prescribing. I'm Charlotte Osborn-Forde, and I'm the Chief Executive of the National Academy for Social Prescribing. If we could have the next slide, please. Here we are. I'm going to give you an overview of the developments in social prescribing, and really start with a very brief introduction as to what social prescribing is and why it matters. And then we'll just cover some opportunities for the future and how it relates to the faith community, and particularly the really important report and how-to guides which have been published this week. A few words about the National Academy for Social Prescribing. So we're a charity, but we work very closely with government, with the health department, with the NHS and other government departments to try to embed social prescribing across our social and political policy and programs. And we have 5 core aims: connecting up the system, and that's absolutely what we're talking about here today, recognizing the huge breadth of activity which happens in different communities and how it should be better connected to the NHS, to public health, to job centres, prisons and other parts of the public service and the private sector, to explore and look at innovation and where there are really good ideas and developments in communities or at national level that could be scaled to improve people's health and well-being. Driving investment, particularly into smaller community and neighbourhood organisations, helping policymakers and others recognise the huge value of the work of community and faith organisations. Making sure that the things that we develop are evidence-based and that there is really robust and accessible evidence about social prescribing and its value, and particularly looking at data that can demonstrate social prescribing has an impact on the wider health service. And lastly, awareness. So making sure people know that that being active in your community, that being physically active, creative, connected, and that sense of belonging is really good for your health, that there are more that you can do than just taking a pill and engaging in medical care, and making sure that people are aware of how to access the benefits of social prescribing. Next slide, please. Thank you. So a quick overview of what is social prescribing. It's been something that's emerged, particularly in England, over the last 20 years, being led both by GPs and community leaders working together. But actually, we only had an international and academically recognised definition last year. And this definition has been co-created with academics, GPs, health leaders, faith leaders in about 30 countries last year. And what it tells us is that essentially social prescribing is a process. It's a means for trusted individuals in clinical settings, such as doctors and nurses, and community settings, such as faith leaders, to identify that a person has non-medical health-related needs and to connect them to non-clinical support and services in the community, like a warm welcome space or a community cafe, a food bank, information and advice. And the process being a co-produced social prescription. So that process of working with a person or patient, understanding their needs, what matters to them, and what they enjoy and would benefit from, with the ultimate goal of strengthening community connections and improving health and well-being. Next slide, please. So we've made huge progress in England since social prescribing became part of universal NHS care in 2019. Social prescribing was made available in GP practices through the GP contract, with GP practices being able to recruit social prescribing link workers to provide that holistic support to patients. And since then, we now have about 3,500 or even 4,000 link workers. Nearly 3 million people have been referred by their GP or their medical practice for support from a link worker. And that's meant that significant investment has come through the NHS via the GP contract to social prescribing link workers. And there's a commitment for further expansion. Now, what I should say is there's not been commensurate investment into the voluntary community and faith sector to provide that support in the community. And that's one of our core ambitions at the National Academy, is to design new models of investment, bringing funders together to help make sure that community and neighbourhood groups get the resources they deserve to deliver some of the activities. Next slide, please. But even with that, next slide, please. Even with that, that barrier of lack of strategic investment into neighbourhoods, we have made really significant progress through the mechanism that we have. And our data shows that there are significant reductions in GP appointments and in unnecessary unplanned hospital care and emergency care, because people are better able to manage their health. They're well connected to peers and friends and their community. They have better health literacy. And so we are seeing that it is reducing demand on the NHS, and that there's a really good financial return on any investment into social prescribing. We've analysed lots of different studies, academic research and data, and it's typically between £3 to £7 of value for every pound invested. And of course, we now have lots of really robust evidence that being active in your community and being connected to your community through social prescribing directly improves your physical and mental health. Next slide, please. Just to highlight this particular report, which we published at the end of last year, which covers all of the different data and evaluations we could find within the NHS that demonstrate social prescribing is an effective tool, and therefore there should be increased investment from the government and from the NHS in social prescribing approaches. So if any of you on the call today are out there championing social prescribing with commissioners, funders, clinicians, we hope this will be a useful tool for you. Next slide, please. So we are at a really critical moment in health, as many of you will see just from the daily news, and there is a large consultation happening at the moment in different forms from the government. It's called Change NHS, and it is around shaping an NHS fit for the future, with what they're calling a 10-year plan for the health service. So we have, between now and the next few months, a critical moment to be advocating for new models of care into the NHS, new investment models, new operating models, and really this is a key moment for us. So we have been working across our stakeholders in different sectors to identify what are the most important things that should go into that 10-year plan to help social prescribing grow and flourish push and help more people with mental and physical health needs. And the first and most important, we feel, is that social prescribing should be available in all care pathways and to all ages. So not just linked workers in primary care and GP practices, but anyone accessing the NHS should be offered the opportunity to talk to somebody about their non-medical needs, their financial issues, their home life, their loneliness, isolation, their spiritual needs, and be connected to opportunities in the community. And we've just specified there on the slide the other elements that we're talking about. But I think for us today, thinking about the value of the faith communities, if we can introduce that within the NHS, there will be far, far more patients advised, activated and motivated to access activities and support in the community, and not just to see that the only option they have for their health is the medical pharmaceutical approach. And of course, the 3 shifts which the government are talking about are very well aligned to that, moving care from hospitals to community, better use of technology, that could be digital directories of community activities, and focusing on preventing sickness, not just treating it, ideally aligned to the concept of social prescribing and the value of community and faith organisations. Next slide, please. So just to think specifically about the value of social prescribing as an approach and as an emerging infrastructure, linking in much more with faith communities, it's a huge area of potential. So not only do we know that there's very valuable, effective, sustainable, untapped assets in communities that could be better aligned with our very stretched NHS, there's huge altruism, compassion, drive to make a difference that is within our faith communities, our volunteers, our community leaders, and actually energizing that and connecting it into the NHS can help the NHS to manage its existing pressures and demand. But what we also know is if we can work better together, if we can build those bridges that social prescribing offers as a mechanism, we can reach more people who might not trust the NHS, who might be from more deprived communities, who might face challenges, life inequalities, and may not feel comfortable accessing healthcare in the way that it's currently accessed. If they can, faith communities play that key role of working collaboratively with the NHS, as we've seen in this report, that can reach more people, which can only be a good thing. And I think the other key element of the faith communities and the work that we've already started is the fact that it is across different faiths and interfaith. And just to give you the example, you may know about the event in the House of Lords chaired by the Bishop of London. That was back in October. Such a powerful event to have leaders from different faiths convening together around shared objectives. So we had representatives from the Board of Deputies of British Jews, the Muslim Council of Britain, the Sikh community, as well as the Christian faith, all coming together around this theme of making sure that the most vulnerable and unwell in our society are able to access the support that is available in communities. And that's a hugely positive and valuable reason for us continuing this work. Next slide, please. Just to say that social prescribing was developed in England, and England is the first country to offer it as a universal part of healthcare, but it's taking off rapidly across the world. And I just wanted to say a little about what's happening in the USA. So I visited with a colleague New York on Monday, and I presented the work of the Academy and of the developments in England, including this report and the work that we've been doing around the faith community. And it was of real interest to leaders in New York and in America for exactly the reasons I've described, that it is a way of drawing different faiths together in collaboration. And it is a way of working across different sectors, but it's also hugely evidence-based. And if you're interested in social prescribing across the world, there's a QR code there for you to read our latest report with the World Health Organization. Next slide, please. And I think if you would like more information, do check out our website or follow us online. But I'm going to hand back to Esther now. Thank you.
Brilliant. Thank you so much, Charlotte, for setting the scene for us so clearly. And we really value the relationship that we have at ChurchWorks and the Good Faith Partnership with the National Academy. I am going to hand over now to my colleague, Dr. Marianne Rozario, who is working at Theos and who has been the lead researcher on this project. And Marianne is now going to talk us through the findings of our research.
Thank you, Esther, and thank you to all of you for joining us today. Our report, as Esther mentioned, Creating a Neighbourhood Health Service, the Role of Churches and Faith Groups in Social Prescribing, is the concluding report of an 18-month research project generously funded by the Sir Halley Stewart Trust between Theos and the Good Faith Partnership, exploring the role of faith groups for social prescribing across England. The NHS and social care services in England are stretched to breaking point, grappling with high record demand for GP appointments and secondary care services. Yet, reportedly 1 in 5 GP appointments are not for medical reasons, but rather requests for help with issues like loneliness, housing, or debt. Social prescribing can be part of that preventative solution and play a role in Wes Streeting's ambition to turn the NHS into a neighbourhood health service. Churches and faith groups not only contribute significantly to social prescribing, but with their focus on community, relationship, and holistic well-being, they can play a foundational role in preventative healthcare. So we set about on this research project. As you can see from our key research areas, we wanted to showcase examples of social prescribing groups run or supported by faith groups. We were interested in the relationship between faith groups and social prescribers at a local and at a national level. And we wanted to explore the advantages, but also barriers to a better integrative approach between the two. So what did we do? Between October 2023 and July 2024, we conducted a scoping survey completed by over 50 link workers, interviewed 37 individuals, including national NHS professionals and regional and local social prescribing leads, as well as faith leaders and representatives, held 3 focus groups with relevant stakeholders, and visited numerous activities and services throughout the country, which feature in the many case studies we have throughout the report. Before summarising the findings of our report, I wanted to share with you the stories of some of the individuals that I met. They feature in these orange boxes throughout the report, and all the names have been anonymised. When I went up to Lancaster, I met a 70-year-old woman who I've called Eleanor, who lives with her disabled daughter. Her husband had died during the COVID pandemic, and she had no other family or close friends still living. A local GP connected Eleanor to volunteers at a local church who were offering to regularly call isolated members of the community. And this was a real lifeline in a time when she was feeling the loneliest. Having someone simply on the phone to talk to weekly was what she really needed. When I went to Manchester, I met a man who we called Bob. He was in his kind of mid-90s. He lived in a small flat in the outskirts of Manchester. And at the start of the year, his energy supplier wrongly mailed him a bill for over £3,000, which resulted in him, sadly, considering taking his own life. Bob met a pastor from a local church walking down the street, and the pastor invited him in for a cup of tea at the church cafe. As it happens, social prescribing link workers based themselves at this cafe on a regular basis, and they were able to help Bob appeal against the extortionate energy bill and in addition ensure that the council fixed the mould in his flat. Bob's now a regular at the church cafe, participating in board games until closing time. Now on to the findings of our research. Our research found that faith groups across the country already host a wealth of friendly, welcoming and referable activities in the report. In the report, we identified numerous activities and services like those you can see in the images, including advice groups, arts and crafts courses, befriending, bereavement groups, cafes, choirs, debt courses, English language classes, exercise classes, food and clothing banks, listening services, mums and tots groups, wellbeing groups, and many, many more. We found that faith groups act as one, anchors of the community, meaning that they knew and were known by their community. They were trusted and were there for the long haul. 2, churches and faith groups were well networked amongst each other and the voluntary sector and had a considerable ability to convene. 3, they offered resources through buildings and volunteers. Both of these assets have a great advantage to link workers who are in need of activities and services in locations at the heart of communities and run by people willing to care for their patients. And 4, faith groups provided pastoral and spiritual care, which act as a preventative role whereby people are able to access advice and support to prevent escalation to more serious issues. However, our research also found some barriers preventing an integrative approach between faith groups and social prescribers. The language, acronyms, and systems of the NHS were hard to comprehend to anyone outside the system, and even the term social prescribing itself was not well understood beyond health circles. Connections between faith groups and social prescribers were sporadic, working very well in some places, but non-existent in others. And the high turnover rates of link workers were noted as a barrier for continued connection. Stretched capacity on both sides was noted, as well as unnecessary administrative processes placed on faith groups to begin accepting referrals, as well as faith groups not always being quick enough to respond to needs. A single online database of activities in a particular locality was desired, although, as we laid out in the report, a number of these do exist, but there are issues in keeping such a database funded and updated. Desired additional funding for activities provided by faith groups, because they too are limited by resources and capacity. A fear of proselytization or of faith groups being too overtly religious was also brought up, but was highlighted as a perceived fear rather than the reality. Faith groups encourage link workers to visit and participate in their activities to overcome this. Despite these challenges, across the board, we found that health professionals and faith groups alike were positive about the suitability of faith group activities for social prescribing, with consensus at all levels of the health system that better relationships between the two will help to support more of the people in greatest need. We suggest that by forming better relationships between faith groups and healthcare practitioners, through active networking, engaged partnering, and forward planning, social prescribing can be revolutionized to neighborhoods, places, and systems level. So these 3 tools of relationship building: 1, active networking. Active networking requires both link workers and faith groups to actively reach out to the other on a regular and constant basis to share information. So, for example, as we highlight in the report, Ebenezer Church in Bristol and Broadmead Community Church in Northampton bring together in a regular forum social prescribers, community workers, faith representatives, NHS professionals. Or, for example, the CEO of Befriended, a Christian charity in Sussex, regularly meets with her local link workers for tea and cake to chat about what her charity offers, including a community choir, exercise classes, outings, etc. 2, engaged partnering. Engaged partnering between faith and healthcare representatives requires collaboratively working together on a specific project or on a more informal but regular basis. For example, a link worker in London spoke to me about partnering with Riverside Vineyard Church to offer weekly art classes, or how link workers in Burnley attend Church on the Streets Cafe on a monthly basis, situating themselves there so they can meet the need as it walks through the door. Thirdly, forward planning. Forward planning is about looking ahead towards an even more integrative approach, requiring strategic conversations at the neighbourhoods, places, and systems level. For example, at a neighbourhoods level, Caris Medical Centre, a Christian GP practice, set up Caris Neighbour Scheme as a way for the local churches and community to help the emotional, social, and spiritual needs of the community, which they realised were just as important as the physical needs. So the questions to be asked is, how can national leaders in social prescribing work with national faith leaders? How can faith activity be better integrated at the level of ICBs or at PCN level? In sum, in order to actualize the vision of a neighbourhood health service, we believe we must recognise that faith groups have a huge potential to strengthen and increase access to social prescribing. A proactive collaboration between faith communities and the NHS should be encouraged, and this will ultimately be done through relationships and investment. Our report highlights recommendations at the level of neighbourhoods, places and systems for better relationship building between the two to achieve this better integrated approach, and ultimately to improve the well-being of the people in greatest need in our communities. Claire will shortly highlight some of the specific recommendations we set out in the report, and Esther will showcase our how-to guides for link workers and faith leads. But before that, I'd like to introduce Stewart and Maaria to share with us a little bit about the role of social prescribing at Ebenezer Church in Bristol and through the Muslim Youth Helpline, both of which of these feature as case studies in our report. Stewart, over to you.
Great, thank you for those thoughts. It's an encouragement to us. My name's Stuart. I'm a church leader and part of a key leadership team in Ebenezer Church in North Bristol, an area of a housing estate of mixed private and council housing. We're not a big church, just a Sunday gathering of around 100, 120 people from all backgrounds, socioeconomically, ethnically. And it really looks like what our community is like. And we're a non-denominational church, but we're passionate about our local communities change for the better. And this ultimately can look messy and beautiful. So I guess like many people on this call, our journey from COVID was how do we reconnect with each other and with our local communities? So much has changed. And we went on a bit of a journey of bringing together some of our community outreach stuff that we did, joining with the Warm Welcome campaign in the winter of 2022, and bringing together activities where spaces where people could meet either intergenerationally or kind of in different people groups. I'm going to just give a glimpse of some of the things over the last couple of years that we've run by spaces. So we had Kintsugi Hope Wellbeing groups. We had a footprints group for senior citizens. We now have around 45 gathering each week within that group. We have a community cafe, which happens this morning. There's food always in all of these spaces, and places where people can overlap with their lives, and across generations as well, which is a really key thing. Our food bank outlet, we are blessed to have North Bristol and South Gloss Food Bank staff offices based in our small building. And there's an overlap of vision there with what happens, not just in our community, but right across North Bristol and South Gloucestershire. A community breakfast, an after school hangout for primary school children and their families. Who doesn't love a Fish Finger Friday, where you get food together as family in our after school hangouts. And we also many one-off events that we run between anything from Christmas banquets for seniors to community pancake parties. A special one I love is a peace feast where we bring people from different cultures and faiths together. I'm not saying all this just to kind of exhaust, it feels exhausting, but to say that actually, ultimately, that journey from starting those warm spaces and new warm spaces was actually a space where we could encourage community to gather together, to build trust, and ultimately connect and give something of themselves and their time and their skills and gifts. And in these spaces, we also had places where we brought in different services, so anything from NHS talking therapies, the Bristol Energy Network. We had mini health checks from a local health organisation. Social Prescribers will be coming, had a meeting yesterday, and they've committed to once a month coming into our space, back to work projects. All those kind of people kind of coming and gathering in these spaces so that people don't have to jump through hoops when they want some more support, etc. So our encouragement is, from what we've experienced, is about investing our time into relationships in communities at different levels. And I guess one of the things that maybe it's hinted at already is that we have been helping coordinate for years now, actually, a networking breakfast, bringing together representations from different organisations in the community, the schools, police, faith communities, counsellors, food banks, charities, social prescribers, a place where people share what's happening, work together maybe on common challenges and provide support to each other. Another thing I would encourage is around looking for key partnership organisations in your community, making sure we don't duplicate stuff at the same time, ways to communicate together, to promote each other's activities. And for us, that's about 5 different organisations, including a school, the food bank, 2 churches, and a youth organisation. Partnership ultimately is key. And finally, even taking that online and creating a space, maybe on social media and local Facebook groups or next door, where residents can share and celebrate the good stuff in communities, changing the narrative in our communities and providing a space where all can connect, whether it's online and offline. That would be something we'd encourage. So thanks for the opportunity to share.
Thanks, Stuart. That's really, really helpful. Thanks for all those examples as well. You must be very busy. I'll now hand over to Maaria, who's going to talk a little bit about the work that she does.
Thank you so much. Hello, everyone. Firstly, it's just great to be here, and it's great that we're talking about bringing communities together for communities, and especially highlighting that the great work communities already do for the betterment of society. I mean, I'm sure everyone in this room already knows that, but it's great that we are now connecting the dots and actually having a platform to discuss these great people and these great places that exist and acknowledging them. I am the chief exec of an organisation called the Muslim Youth Helpline. We have been operating for 25 years. We are a national helpline that supports young people, and in particular young Muslims all across the UK. And our story really is, I guess, the poster story for social prescribing. We were set up by 3 18-year-old boys, and the idea was that they wanted a helpline that represented them and also was a helpline that they could engage with and support. And they didn't think that a helpline existed. So they created this small, unique helpline from their bedrooms, and it operated for a few hours each day out of London. And since then, it's grown into this national helpline that operates nationally for all young people. And each year we support over 15,000 young people. Now, that's the foundation of our work, and it's all about personalized care. The helpline operates because you have 45 minutes with a support worker, with a helpline officer, with a volunteer, and it's to provide emotional support, but it's also for the young person to utilize those 45 minutes however they like. Now, each service user does not know what kind of issue will be brought to their attention during that call. But the idea is that they don't need to know, because it's personalized care. It's about that young person being empowered enough to direct those conversations. And that's really, really important for us. So even before we link our beneficiaries to any referrals or any signposting that happens, that personalized care is already going on. Now, in addition to the emotional support and the listening ear that we provide, it is to identify that as a helpline, we cannot answer all the questions, and that there are unique and amazing organizations that exist that are doing wonderful work, and that we need to connect our young people to those organizations. So that's where our referral list and signposting works. Signposting, of course, is slightly easier to do. Referrals are a bit more difficult, but we're growing the referral list so that we can build a two-way relationship with great organizations. And through our data, we can see what is the biggest uptake, what types of organizations work best for young people, and we're always developing that list. So it's not a static list, and it's something that is ever evolving. Number one, through acknowledging the types of concerns that come into our helpline, the types of issues that young people are grappling with, and also what types of services still exist, whether they still work for young people, whether they still have a purpose for our young people. And that's really, really important to understand that grassroots organizations have their own problems, and we've either have to support them and encourage their work, but also to acknowledge those and support them in other ways as well. There are many reasons why, beyond the helpline services, social prescribing is so unique to faith communities. Young people engaging with these services and the discussions that they have around these services is amazing. We map out those grassroots organizations in the communities who have, and to understand who have high impact in those communities. Now, what we've been doing in the last 2 years is identifying the top 5 regions of support in the UK, and then the top 5 primary concerns in each of those regions, and then identifying regional support services in those areas. Now, when we look at mental health services in particular, we already know that young people are hit with wait lists. And the idea is that regional services, although they may also have their fair share issues of like long wait lists, we can get young people to more accessible, safer routes to getting support. And that's really, really important for us. The biggest barriers to support for young people is finding trusting services, finding accessible and free services. And we found that through social prescribing, through identifying regional support services, we've been able to connect more young people to additional support beyond the helpline. And that's been our biggest achievement. Getting young people to even call us and build that relationship and that trust is sometimes quite hard and difficult, but actually getting them to engage with additional support services has been very difficult. But actually what we found is with regional services, it's been far easier. Religion plays a huge role in the lives of the young people we serve. And to at least understand faith better, social prescribing helps us engage better with other faith and culturally sensitive communities and organizations. And by doing mapping exercises, we haven't even scratched the surface of the wonderful grassroots organizations that exist. And we know that by continuing to do this mapping organization, when we look at top regions, top concerns, we're building a huge list of resources that can help so many young people. And we're so excited to do this. And we've been working with big funders actually to show them the impact of this work and get funding to continue this because it's so important and vital. If I was to encourage other faithful communities and organizations about why this is so great, I mean, from the mental health perspective, I would say that, to avoid big wait lists, to engage with high impact support, and to also engage with services that are accessible and needed. It's definitely an important offering, and that we should engage with local services through social prescribing. I guess one of the biggest lessons we learned from COVID was how impactful local grassroots organizations were, and that the huge piece of work that they were able to do and undertake. I know as an organization, we worked very closely with Barnardo's at the time, and they were one of the first organizations to say that there's a lot of work that we cannot do. There's large pockets of communities that we cannot engage with, and we don't have that support. And so this is how the work with social prescribing came about, and especially with organizations that lead with faith. It was very important for us to be leading those discussions and engaging with faith organizations, especially. So thank you for listening. I hope that I was able to shed some light on some of the work that we do, but also why it's been so integral to our work and to supporting young people in particular. Thank you.
Brilliant. Thanks so much, Maaria and Stewart, for sharing the work that you are doing on the ground with local communities. And thank you so much, Marianne, for unpacking some of the findings from our report. As Marianne mentioned, we wanted to make sure that our findings are useful and accessible so they can be used by people who are working in the social prescribing and faith space. And so for those working at a local level, we have created 2 how-to guides, one which we've made for social prescribing link workers and one which we've created for faith leaders. And we wanted to briefly show you those how-to guides now. So I'm just going to share my screen with you. So hopefully you can see. This is our how-to guide for faith leaders. And the faith leaders and the social prescribing how-to guides look fairly similar. They have this first section on context and why we're talking about faith and social prescribing. Then we have this section on next steps, and these are divided into networking, partnering, and planning, which follow those 3 steps of relationship building that Marianne was sharing. We then have the FAQs section about how faith groups and social prescribing link workers can work together. And then at the end of both of our guides, we have a list of activities that faith groups can offer to social prescribing link workers based on those that we heard about through our research. And then we have this local activities fact sheet. And we suggest in our how-to guides that as a faith leader, if you are connecting with your social prescribing link worker, that you print off this fact sheet template and just fill out the basic bits of information about the activities that you have in your faith group, the audience for those activities, what it involves, who it's for, who it's not for, and then also provide information around safeguarding. And if you can give that to your social prescribing link worker, that gives them the information that they need to be able to link and refer the right people to your activities. And so this fact sheet is included in our how-to guide for faith leaders so that you can print it off and use it. And there's some guidance here for having that, making that initial contact with your social prescribing link worker. But we've also included it, oops, sorry, I just need to find the right tab. We've also included it in our how-to guides for social prescribing link workers, that we've got this context setting, our next steps, FAQs, and then here at the bottom is that fact sheet. And the aim is that these how-to guides distill all of the kind of practical recommendations for those of you who are working at a local level, and that these can be your step-by-step guide for how to build relationships with one another and collaborate together. You can find our report and our how-to guides are both on the Theos website and also on the ChurchWorks website, and we will share both of those in the chat and also in our follow-up email to all of you. I'm going to hand over to my colleague Claire now, who is going to talk through the breadth of our report recommendations from a neighbourhood, place and systems level. So over to you, Claire.
Brilliant. Thank you so much, Esther, and thank you so much, everyone, for joining us today. It's so exciting to see so many people. As Marianne suggested earlier, we have some key recommendations that we've made as part of our report, and it's my job to just really briefly share those with you now. And to achieve this aim of better integrating faith groups with the social prescribing system, we need to see coordinated action at all levels, from the local right up to the national. So how we've structured our recommendations are in these 3 tiers that have been mentioned. So there are recommendations for neighbourhoods, that would be for individual faith groups, for teams of link workers, perhaps for groups of GP surgeries. Then we have recommendations for places, working at that more regional level, at an integrated care system or local authority level, at the level of a diocese or a kind of unity group within a faith group setting. And then we have our systems recommendations, our national strategic recommendations. And we're running on a bit on our timings today, so I'm going to share the briefest sketch of our recommendations, but there are really rich and specific recommendations in the report. So if anything I say in the next couple of minutes you think that's a bit vague, please read the report, and there'll be much more specific recommendations for you at whichever level of those 3 is relevant for you. So at that neighbourhood level, that hyper-local level, our recommendation firstly is to network. So we are recommending that faith leaders make proactive contact with their social prescribing link workers, and use those how-to guides to get you prepped for that conversation, so that you, as busy people, the link workers as busy people, can get the most out of that connection time together. Then keep your social prescribing team up to date with your activities and your timetables. Vice versa, we urge link workers to seek out your local faith leaders. You can find out how to do that in the how-to guides, and find out who they are, what they're about, and what they're offering. We suggest that faith leaders and link workers then make use of local forums and community groups like the ones that Stu was talking about at his church, to discuss the local needs and priorities and make plans together, and work together to set one up if that doesn't exist. Moving on then to our recommendations at a place level. I think we might just need to go back one slide to place. Brilliant, thank you. This is where we found that relationships and strategic links were actually the most lacking. And so for faith groups, we recommend that working at that regional level, you seek to join relevant roundtable discussions that already exist, like VCSE alliances, faith alliances. Designate within your regional faith group structures an outreach lead or a health and wellbeing lead who can sustainably build and maintain those relationships. For health system staff at a places level, we suggest that whenever you are setting up a stakeholder group or a consultation around any of your services or strategies, include faith leaders, make sure they're invited and involved as a stakeholder, and consider them in your plans as a potential delivery partner. And that's particularly crucial for strategies and budgets around prevention, public health, and health inequalities, as Charlotte mentioned earlier. And a really important place to start there would be any faith groups that you already worked with during the pandemic, especially those places of worship that did and still do provide vaccination services. Finally, both faith groups and health professionals need to invest at that places level in faith literacy and health literacy training. That needs to go both ways. So at that systems level, we recommend that faith leaders again be involved as stakeholders in the development and delivery of community-based preventative healthcare policies, and use existing vehicles where you can to invite those faith groups along where they've already self-organised, things like Faith Action, the ChurchWorks Commission, the Muslim Council of Britain, and the Warm Welcome campaign would be examples. Again, there are more in the report. Policies, budgets, and funding should be designed to include faith groups alongside the voluntary and community sector, and explicitly state that. And lastly, we are suggesting that a faith lead be instated within the National Academy of Social Prescribing to continue to champion all the really important work we talked about today and represent faith groups at that strategic level of developing social prescribing in this country. So we believe that those recommendations at those different levels together would really change the dial on integrating faith groups into social prescribing. And I'll leave that there so that we have time to hear our last word from Dr. David Smart, who is a recently retired GP, Chair of Action for Happiness Northamptonshire Hub, a trustee for Delapre Abbey, and he's also been a really brilliant member of our research steering group, for which we're very grateful. So David, I'll hand over to you for the last word. Thank you.
Thank you so much, Claire. And yes, I have a passion for whole person care, and I recognise the struggle we have in understanding and enabling this in the NHS and our neighbourhoods. So it's been a real privilege to be part of the advisory group and this meeting of 500 people taking action to progress this. And that's my call, really. How do we act? So social prescribing and faith communities have common aspirations of existing to enable people to flourish and live life to the full. This report, I think, builds bridges and opens conversations between communities. And we've heard many opportunities with case examples of what's already happening. So using the strapline of Action for Happiness, and that's in the chat, I'm part of it. We have an opportunity to build communities which are happier, kinder together. And this isn't just an idea. It's a proven path to a genuine and long-lasting impact. And to quote, that's quoting Matthew Taylor, the CEO of NHS Confederation, in the report Case for Neighbourhood Health. He starts The evidence shows that when statutory organisations in our neighbourhoods genuinely collaborate with their communities, we can unlock the potential for greater economic, social, mental and physical prosperity. Our spiritual prosperity also matters. People with a sense of purpose live longer and have higher levels of well-being. Consideration of the patient's spiritual needs is part of GMC guidance, but is often forgotten or not considered. So these conversations and bridges are important strategically in consideration of the whole person. And the report and toolkit provides strategic leaders, ordained lay leaders and other leaders of faith communities to really share in integrated care partnerships, integrated care boards, health and wellbeing boards, place networks, social prescribing services, primary care networks, GP practices, and our faith communities, interfaith forums, neighbourhoods, and families. So a question for us all is how do we link and work with leaders in other key infrastructure organisations like Association of General Practice Chaplains, College of Medicine, and many other who support future opportunities for the NASP Faith Lead, which we all would like to support and lead to drive this opportunity forward. More webinars has been suggested in the chat. Coming together in these difficult times, we build capacity, potentially sustain heritage buildings, and build trust in faith communities. Trust really matters. So to my mind, the report puts the F in the VCFSE and fertilises the original roots and aspirations of the NHS towards neighbourhood, whole person health creation. So I encourage government and other funders to consider how to support more research into what is needed to enable health creation in neighbourhoods that includes faith communities to be effective, safe and sustainable. The House of Good report describes £1 invested gives a social impact return of £16. This will be a good investment. Thank you.
Great, thank you so much, David, for all of the input that you've given into the report and for the encouragement and passion that you have for engaging communities and faith groups in health and wellbeing. We've come to the end of our time today. Thank you so much for joining us. Thank you for the enthusiasm and the encouragement from many of you in the chat. It's a real pleasure to be able to have you here and to share our report and our findings with you. There are many people that we have thanked for their contribution to our report. However, I want to end by giving particular thanks to the Sir Halley Stewart Trust, who have funded this research project, because none of this would have been possible without them and their generosity. So we're really grateful for that. As has been said in the chat, we will share the slides with you. We will share the links to our report and our how-to guides, and there are already in the chat, there are those links to the Theos website and the ChurchWorks website. Please have a look at the report, have a look at the how-to guides, share those widely. We'd also love to stay in touch with you, and so we would encourage you to sign up to our newsletter, both the Theos newsletter and the ChurchWorks newsletter. If you have further questions or you would like to continue this conversation, we'd really love to hear from you. And please get in touch with us at info@churchworks.org.uk. My colleague Ellie has just put that into the chat. Thank you so much for being with us. We really appreciate it, and we look forward to further conversations and working with all of you. Have a great rest of your day. Thank you so much.